Hello everyone, myself Dr. Vaibhav Sharma. I'll be talking about a topic called as obstructive jaundice. Okay, so the main motto of this video is to differentiate between medical and obstructive jaundice, right? And frequent questions asked with you in abdominal cases of medicine and jaundice cases or mass parabdomen in surgery. What are the frequent questions asked which you will answer from this video, right? Okay, so we will start it. Okay, so coming to the definition means, what is my jaundice means the yellowish discoloration of the sclera. Yellowish discoloration of the sclera and mucous membrane is called as jaundice, which means that the normal bilirubin level is 0.3 to 1.2, and the conjugated or direct, there are two types of the direct and indirect. The conjugated or direct is less than 0.3 and unconjugated is 0.2 to 0.8. Okay, jaundice occurs due to the excess presence of lipid soluble yellow pigments, mostly the bile pigment in the plasma. Okay, so I said there are two type of jaundice. One is the obstructive jaundice, another is the medical jaundice, right? So in viral hepatitis, that is the medical jaundice, right? In medical jaundice we have faint yellow color of the jaundice, and in the obstructive jaundice we have dark olive greenish yellow, more a greenish yellow. Is just to differentiate, but main is the examination and test part which will differentiate. Okay, another DD for jaundice which may be which is may be confused with hyperkeratinemia. It is hyperkeratinemia. In jaundice there will be discoloration of sclera, right? But in hyperkeratonemia there is no discoloration of sclera, plus it is seen in vegetarians who eat excess quantity of raw carrot, right? So this is differentiating feature of this. Now coming to the main part means we will go from basic biochemistry, basic to the surgical part. Okay, so coming to this, if you see this is the section of lobule and these are the hepatocytes. Okay, you can see the bile duct here, small bile. This is called as canaliculi. The canaliculi join to form the terminal bile ductules, which is also called which combine to form the perilobar bile duct, which combine for the interlobar bile duct. Means bile duct is formed from many radicals. You can say the radicals type things. Okay, this is also called as biliary tree. Okay, so coming to this part, from this the bile flow occurs, and all of this interlobar bile duct combine to form a right duct. Let me change the color. A right, a left, which combines to form the common hepatic, and where the cystic combines to form the common bile duct. This is the common bile duct. Okay, this combines with the peripancreatic duct opened into the second part of duodenum. The second part of duodenum is the landmark. Opening of this is the landmark for the foregut and the joining of the midgut. Okay, right. So coming to the basic of bilirubin metabolism. Okay, bilirubin metabolism. So coming to the basic, RBC has hemoglobin, it contains the heme. Okay, when there is a when there is destruction of RBC due to any cause or due to aging, the life cycle of RBC is 90 to 120 days. Okay, 90 to 120 days. So the RBC will break down and the heme is formed. From heme there comes a enzyme called heme oxygenase. Okay, heme oxygenase, and this convert the heme to biliverdin. When the biliverdin is converted to bilirubin by biliverdin reductase. Okay, biliverdin reductase. This bilirubin which is formed, it is non-soluble, so it is insoluble in water. It will not be absorbed by hepatocyte. To go into the hepatocyte, it has to combine with albumin, right? This has to be combined with albumin. This entity, what I am telling you, is taken up by the hepatocytes. Okay, in hepatocyte conjugation occurs. So before the hepatocyte, if it's going to increase, this is the unconjugated form. After the hepatocytes, in hepatocyte it occurs, the conjugation occurs. Okay, so after the conjugation, it is done conjugation with glucuronic acid, UDP, UDPGT, uridine diphosphate glucuronyl transferase. From there, the bilirubin monoglucuronide and diglucuronide are formed. See, this this bilirubin monoglucuronide, this is transported to canalicular bile. What we saw, the canalicular bile, to this by MRP2, multi-duct resistant protein 2, this is the important part. So before the hepatocyte, if bilirubin is raised in hemolytic disorders, like where the RBC is breaking down, in child hemolytic anemia, okay, there the unconjugated form will be. But after the hepatocyte, like viral hepatitis or some medical kind of where hepatocytes are also dearranged, their conjugated, unconjugated, both will be. But after liver, if there is obstruction to the flow of bile, it will generally increase the conjugated part. This thing has to be remembered. So I said that this is a type of biliary tree. Okay, biliary tree means all the canaliculi are joined to form main ducts, just like a tree, where and this simulates what, same as that, both are joined and form the right hepatic, both joined to form the right hepatic, left hepatic. This is the common hepatic duct, right? This is the common hepatic. At the joining of cystic duct, this becomes the common bile duct. This becomes common bile duct or CBD. Okay, this thing has to be remembered. Okay, so let me explain you something. Let me explain you main thing of this. Okay, let me explain you main thing. What you have to remember is this part. Okay, let me explain you. So see, this what I want to tell you, that see, bile will flow from this to this to this. Okay, so after hepatocytes, if there is a block means if there are some stone, if there is some stone, intrahepatic stones, this is called as intrahepatic stones, or in the common hepatic duct stone is formed, or in the common bile duct the stone is formed, it can be due to obstruction by stone, by tumor, by worm. Okay, stone, tumor, worm, anything which causes the obstruction of the flow of bile, this will cause obstructive jaundice. This thing has to be, so there has to be a free flow of bile. The bile has to flow from here to into the duodenum, and from here it goes into this intestine part. From intestine it again goes to the ileocecal part and again absorbed, called as enterohepatic circulation, Entero means gut, hepatic means liver, circulation means it keep on repeating. So okay, and some part is excreted into urine, called as urobilinogen. Some part goes to the stool, called stercobilinogen. So if this is blocked, means no bile is going, bile is not going, which means that stool and urine color has to change. That's what in history we ask for the stool and urine color of the patient, right? Okay, so coming to the one more entity, what frequently asked, see, if there is acute cholecystitis, acute means there has to be gallbladder, something like that, let it be anything. Okay, this will not produce jaundice. Acute cholecystitis will not produce jaundice. this will not produce because this is separate entity from this. This is separate entity, this has to flow, and this is separate entity until unless some conditions are there, like Mirzi syndrome. Mirzi means there is stone here, okay, stone. This causes the external compression. This causes Mirzi means this is the right hepatic, left hepatic, this is the cystic duct which is joining, and here is the stone. This is going to press the common hepatic, this is going to press the common hepatic, this will press, and this will cause the this will hamper the flow of bile. So in Mirzi syndrome it will be there. Second, carcinoma gallbladder. Second is carcinoma gallbladder. This means there is direct infiltration into the liver, and this will cause jaundice. Otherwise acute cholecystitis will not cause jaundice. This question has to be in your mind, okay. This is what I want to tell you, the main part, okay. Now coming to the jaundice, this is the yellowish discoloration of skin, sclera and mucous membrane. I told you already there are three types. One is pre-hepatic, hepatic, post-hepatic. What I told you, pre-hepatic means before conjugation was happening in hepatocytes, okay. Pre-hepatic means before liver. Before liver means hemolytic anemia. This is done in hemolytic anemia. What is increased is unconjugated part. Done. Okay, in hepatic part there is conjugation. I told you in hepatocyte there the conjugation occurs. So some part where conjugation is occurring is called as conjugated, plus the other is called as unconjugated. So there both will be increased in hepatic. For example, hepatitis, cirrhosis, and some diseases like Crigler-Najjar, Dubin's and Rota. We'll see this, okay. And other entities post-hepatic. What I am concerned about, being a surgeon, I am concerned about the post-hepatic part, okay. This is called as conjugated in this post-hepatic conjugated part. I told you already that it can be due to post-hepatic. This is not gallstone, I'm so sorry for that. This is CBD stone, okay. CBD stone, malignancy, inflammation of the common bile duct due to malignancy, inflammation, or worms also. They also causes obstruction in the flow of the bile. This is called as conjugated. This is called obstructive jaundice. I am more concerned, being a surgeon, more concerned about obstructive jaundice. Okay, done. So what we saw that there is conjugated and there are some diseases which will be asked in your exam, in your NEET or something. Just go through it, you have to remember. In conjugated there occurs, conjugation was there in hepatocyte, and this was the transport by MRP2. So there are two entity called as Dubin-Johnson and Rotor syndrome. In Dubin-Johnson, MRP2 protein is there which is defective, and all the serum gamma glutyl transferase and serum bile acid are normal. Clinical feature is mild conjugated hyperbilirubinemia, conjugated hyperbilirubinemia, okay, because it is after the hepatocytes, okay. The most important differentiating feature is there is dark pigment in liver. In Dubin-Johnson, D for dark pigment. Dubin-Johnson, they have a dark pigment in liver, and there is also accumulation of lysosomes in the centrilobular. The accumulation of lysosomes in centrilobular hepatocyte cause granular pigment, means there is the pigment present, dark. Dubin-Johnson dark, okay. And there is a bromosulfide rise in plasma concentration. In bromosulfalin test, what we do, there is a rise in the plasma concentration 90 minutes after injection, okay. And here no pigment is there in rotor में कोई pigment नहीं होता है, pigment होता है Dubin-Johnson में. This has to be differentiated from, the question will be asked like a patient is having a conjugated bilirubinemia, and there is on the cross section of the hepatocyte, there we are seeing that there is dark pigment in the liver hepatocytes are darkly stained. This will go to the Dubin-Johnson. Now come to the unconjugated bilirubin. I told you unconjugated means before the hepatocytes. The conjugation part occurs in the hepatocytes. Before the hepatocytes is the hemolysis is there, more hemolysis, that is causing the unconjugated part. So there is three entity means, I'll tell you, one is a Crigler-Nazar syndrome, another is the Gilbert syndrome. Crigler-Nazar, Gilbert syndrome. In Crigler-Nazar we have type 1, type 2, another is the Gilbert syndrome. What we have to remember is type 1 is very bad, type 1 is very bad, okay. So the bilirubin is greater than 20, type 2 less than 20, and Gilbert syndrome is mild. Patient can live with Gilbert syndrome, it less than 4 milligram per dl, okay. So the main important point is the color. See, bilirubin fractions, more important, the bilirubin UDP glucuronidase transferase. This is the enzyme bilirubin UDP glucuronidase. This is typically absent, that's why it is the bilirubin is very much bilirubin is too much in this, okay. Bilirubin is too much in this, okay. This is typically absent. If you go into the type 2, it is reduced 0 to 10% of normal, and other, if you go to the in this it is reduced, it is not absent, it is reduced to 10 to 33% of normal value, okay. This is 0 to 10%, and in type 1 it is totally absent. That's what greater 90% unconjugated, 50% unconjugated, mainly diconjugated, it is seen, okay. So hepatic histology normal, increased lipofuscin pigment, this you have to remember like that. This main important, Crigler-Nazar 1 is very bad, greater than 20, 2 less than 20, and Gilbert less than equal to 4 centimeter. This is about the unconjugated bilirubin. Now coming to the obstructive part, obstructive jaundice. What I am more concerned about is obstructive jaundice. I already told you there has to be a obstruction into the flow of bile. Bile is flowing, and has to be obstruction. What obstruction it can be? Obstructed a post-hepatic part. So a post-hepatic, so there is conjugation of this conjugated bilirubin is raised, okay. So we can define it like, if this is CBD, we can tell luminal means inside the lumen, then luminal means inside the lumen, intraluminal, extraluminal causes, okay. Luminal means intraluminal, mural means, okay, let me change it, this is mural, intramural, okay, and extraluminal. Luminal means inside the lumen, mural means into the wall, and extraluminal means outside the wall. So luminal can be I told you, gallstone, parasite, biliary slush, polyp. These all things can cause obstruction in the flow of bile and causes jaundice. Other are the mural. Intramural means stricture, sclerosing cholangitis, colloidal cyst. This all in the wall of the CBD, this is causing this. And other is the extraluminal, outside the lumen, compressing from outside to the CBD. It is cholangiocarcinoma, GB carcinoma, head of pancreas, and periampullary carcinoma, right? Okay, let me tell you one more thing, very important. In periampullary carcinoma means around 2 centimeter in ampulla. Ampulla means the both common bile duct, perium, and the pancreatic was joining and opening into the duodenum, right? Both were joining, opening the duodenum. This is duodenum, both were joining, opening into the duodenum. So around 2 centimeter of the ampulla of Vater, it is called as periampullary carcinoma. Tumor around 2 centimeter ampulla of periampullary carcinoma. There is waxing and waning of jaundice, means when the tumor grow, it will block the CBD. If this is CBD, tumor is growing, blocking the CBD, bilirubin will rise, it will get absorbed from the body. But as it rises, as it grows, the blood supply is not that much to the tumor. From the center to the periphery, it sloughs. When it sloughs off, most of the tumor sloughs and goes and shaded into the common bile duct. So what happens into the duodenum, shaded into the duodenum, and there is a space again where the bile can, so waxing and waning. Waxing means it increases, waning means it decreases. So this is the part of the periampullary carcinoma where the jaundice will increase when the tumor grows. When there is necrosis, it will again decrease because there is again increase in the lumen. Okay, now the again question will arise, where to see the jaundice. So jaundice can be seen into the places like sclera of eyeball, nail bed, lobule of ear, tip of nose, undersurface of tongue, mucous membrane, all things. Remember, it is seen into the sclera of eyeball because the bilirubin has affinity to the elastin fibers. Let me tell you, bilirubin has, bilirubin has affinity to elastin fiber of sclera, so it is getting and deposit into sclera. And you see in the sclera how you have to see, you hold both the sclera, ask the patient to look down. Okay, I'm sorry, you hold the palpebral conjunctiva and pull it upwards and ask the patient to look down, and you will see into this, you will see the jaundice. First checking of the pallor, you lower palpebral conjunctiva and you just see into the lower palpebral conjunctiva. For the jaundice you have to pull upwards, ask the patient to look down, and you see into the sclera of the eyeball, right into the mucous membrane. Okay, so this was the patient what I saw what I saw into my emergency, and he was having at least 23, the bilirubin was 23. It was a very high cases of this. Okay, now coming to this part, see this. See, I am pulling the upwards and asking the patient to look down and watching this again. So again I'm opening and you can see the yellowish discoloration of the mucous membrane of the patient. So this is a case of jaundice in which you see that. Now coming to this again. Okay, so what are the other question what they will ask you into the jaundice? First, and one more thing, they will ask you where you see the jaundice, in which light you see the jaundice. See, you will not go to the outside, you have just to say we see the jaundice best into the sunlight. Sir, I will take my patient and go to outside and see in the sunlight. It doesn't matter. No, you will not take the patient. I know he also know you will not take the patient, but answer has to be like this: I will take out the patient into sunlight to see for the jaundice, not into the room light. Okay, this question is asked multiple times in your viva, and they will ask you into the sunlight. Okay, this is very important. Now other questions are asked, why there is itching in obstructive jaundice. There is obstruction of this and bile is getting absorbed. Okay, bile salts, bilirubin is getting absorbed. The patient presents with itching. He has the history part, you will take now. It has lot of itching marks. Okay, when videos and YouTube you can see the itch marks in the patient, because itching is due to also called as pruritus. It is due to retention of bile acid. It go and into the dermis part. There we have nerve endings. Bile salt go and deposit into and irritate the nerve endings. Bilirubin, bile salts go and bile acid go and deposit, irritate the nerve ending. That's why patient has itching. You will see lot of itching to back, abdomen, everywhere. This is the hallmark for obstructive jaundice. You have to see this. In pedia, they will ask about it. Kramer's rule, go and just learn it. For example, there are 5 zones they have divided. One is the face. The 5 zones they have divided: one is the face, second is the body, third is this, fourth is the feet, and fifth 5 is the palm and soles. What does this mean? If it is only on the face, it is 4 to 6 milligram per dl. Chest and upper abdomen 8 to 10, lower abdomen thigh 12 to 14, arm and lower legs 15. If it is the palm and sole, it is greater than 15 to 20. This is asked in pedia. Another question is asked, very important question. They will keep you asking into the medical and surgical part. What is the pulse rate in the jaundice, obstructive jaundice? What is the pulse rate? So this is not tachycardia. This is bradycardia, because in the SA node bile acid go and deposit the SA node, and this causes the bradycardia in the patient. Okay, this causes bradycardia in the patient. Now the most important part, what is complication of obstructive? I already told you there is the complication of obstructive ascending cholangitis. Okay, let me show you one part. Let me show you one part. Okay, so see this, I'll tell you, this is very important part. What I have tell you, if there is obstruction, there is backflow of the bile, into the liver. In liver we saw the microstructure, there was portal triad, so there is increased absorption of bile. Again, bile is absorbed systematically it will get absorbed, and this is this is the bad thing by which we see the jaundice. Okay, so okay, so what is ascending cholangitis? Okay, leave it. Ascending cholangitis means when there is infection from the to the bile. What bile stasis is there now, it will see, this is the right hepatic, left hepatic, common hepatic, cystic joining, this is the common bile duct. Here it is blocked, it is going absorbed from this side, it is going absorb right hepatic, left hepatic, cystic, this is the common hepatic, this is the common bile duct. It is getting absorbed. If infection occurs from the duodenum or the infected bile, it will go upside. This is called as ascending cholangitis. Okay, this is called as ascending cholangitis. What is Charcot has intermittent pain, intermittent fever, intermittent jaundice. All the three are intermittent. You have to remember intermittent pain, intermittent fever, intermittent jaundice. What is Reynolds Pentard? See, Charcot's triad, if patient is having cholangitis, you will get fever. Cholangitis, the hallmark is fever plus chills and rigor. This is very important, fever with chills and rigor. Chills and rigor is also seen in UTI. You also seen in UTI chills and rigor. This is the hallmark for this. Okay, fever which in Charcot's intermittent pain, intermittent fever, intermittent jaundice. What is the Raynaud's pentad? When you are not treating the Charcot's triad, you are not treating the ascending cholangitis with antibiotics or anything, or surgical is very less. Now you have to treat with medical first. So patient go in Raynaud's pentad. What happened in this? Patient will go into the shock and altered sensorium. The two things will get added. Let me tell you, intermittent pain, intermittent fever, intermittent jaundice. Okay, this is done. When you add this altered sensorium, when you add altered sensorium plus shock, this has a very fatal prognosis, and the morbidity of 70 to 90% patient will not survive. So you have to treat here in the Charcot's intermittent pain, intermittent jaundice. As you all know that the clotting factors are formed into the, liver, so the clotting disorder will be there because ADEK is not formed, and the clotting factor vitamin K is formed. This is not formed into the liver. So ADK is fat soluble, so this is not formed. So at last I want to tell you, this is just a gist of the differentiate between the obstructive and hepatic jaundice, and you have to differentiate, and you have to take proper history and examination whatever we have told. Okay, this is done. Anything left? No, we have done this. Okay, thank you. We will see you soon.